Good afternoon. Thank you all for coming. We're very fortunate today to have two honored guests with us from the Patan Academy of Health Sciences, or PAHS, as I will call it from here on, from Nepal. PAHS is a medical school based out of Patan Hospital in Kathmandu in Nepal, and they have a very strong rural and remote program with multiple distributed sites, much like we have at Memorial as well. PAHS' innovative program has been deliberately designed in order to equip physicians to work in the underserved peripheral areas of Nepal, where the need is greatest. Memorial has partnered with PAHS since 2013, when Drs. Jill Allison and Sri Malay developed Memorial's International Summer Institute in Global Health Training, or INSIGHT program, with PAHS. This program takes pre-clerkship medical students to Nepal to learn about the deep impact of social determinants of health and see them in a clinical context in a resource-challenged country. More recently, PAHS and Memorial have begun collaborating around program evaluation and postgraduate training as well. So I'd like to thank Dean Shrestha and also Dr. Chidich Paudel for coming here to visit us at Memorial today on their way to present at the SRPC conference coming up in just a couple of weeks. Their Canadian tour will include visits to McMaster, Nazem, and University of Alberta as well. And I'd also like to thank Team Broken Earth for their travel scholarship, which has made Dean Srijana and Dr. Chidich's presence here today possible. So now I'll invite Dr. Sri Malay to just briefly introduce our first speaker. Yes. It's the other way.
That's where my poor eyesight comes in play. So good afternoon, everybody. I'm delighted to see as many people as we have here, considering that this talk was moved at the last moment from Tuesday to Wednesday. So it's lovely to see that many people here. I think that you will find the talks very insightful and rewarding. I first of all want to really heartily welcome our Nepalese delegation, and in particular Dr. Shrestha, who is going to be the first speaker of the two. I welcome you just as much, not that it is intended to be just for one person. But Dr. Shrestha received her MBBS training, which is the equivalent of the MD, not quite, but almost the same as the one that we have here at Memorial University. The MBBS, which stands for Bachelor of Medicine and Bachelor of Surgery, is the one that is used throughout South Asia as a degree. She then went on to do a specialization in pediatrics in Lahore, at the Postgraduate Institute. And she has been working as a pediatrician in the Department of Pediatrics at the Patan Hospital since 1998. She became the Dean of Medicine actually before that she was appointed as the Associate Professor in Pediatrics at the National Academy of Medical Sciences in Nepal in 2005, and later she was appointed as Professor of Pediatrics at the Patan Academy of Health Sciences in 2010. And she has been actively involved with from the inception of PAHS, which started in 2010, am I right?
No, before that.
Before that, in that capacity. And she has been working as the Dean of Science since 2014. And I suspect that she's the youngest Dean of Medicine that we know of and certainly in Nepal, but I think in most countries as well. She has contributed to various national committees related to child health, immunization, and medical education. and she is also actively involved in collaborative research projects on vaccine prevention and disease of childhood. So welcome to Memorial University. There are people here in the audience who have been to Nepal, and they very much welcome the opportunity to hear you talk about the Patan Academy of Health Sciences.
So good afternoon, and warm greetings from Nepal, the country of Himalayas. And first of all, I'd like to thank you all for having us here, and thank you Memorial University for having us as a guest and giving the opportunity to speak about PAHS. And over the next couple of, maybe about half an hour, I'll be talking about what PAHS is all about, what was the purpose of its establishment, how is it different from other medical schools in our part of the world, and where are we now? So this is what I'll be talking about. So if we look at the current realities of Nepal, what we can see is we have very poor health indices. Like we have very high infant and child mortality, we have very high neonatal mortality, maternal mortality, and like, of course, like a very small number of deliveries happen in the health facilities. And beyond that, we have a high regional differences because we have like Himalayas, mountainous region, and Terai. So there's a vast difference in these health indices between the Himalayan regions, the hills, and the Terai. So that is something that is, which is more problematic. Besides the low national health indices, there's a wide range of disparity between different regions as well. And if we look at the human development indices, like Nepal stands at 145 out of 188 countries. And looking at the SAARC countries, it is one of the lower most country with the HDI, just above Afghanistan. And as we know that Afghanistan is a country which has a lot of war going on, but without so much of a war or conflict going on, Nepal still lies in a very lower line in the HDI. And we all know that HDI has a direct relation with health, education, and the income, and these all go hand in hand. If we look at the health services in Nepal, for majority of the people, health services in Nepal is inaccessible because of the geographical terrain and poor road facilities. So it is inaccessible, especially for people living in the rural areas. And besides, it is unaffordable for most poor people because health insurance system is not there in our country. It is just now about to start, and only few districts it has been started in few districts. So phase-wise it will start, but till now there's no health insurance as such. So people have to pay it out of their pocket. So it is, even if the facilities are available, sometimes it is unaffordable to the people. And if we look at the health institution, there are a lot of health institutions, especially in the cities, a lot of private institutions growing up in the cities. But in the rural area, there are very few. Only the government-owned health system, health facilities are there in the rural part of the country. And there, as I said, like most of the things people have to pay on their own. Like there are some medications or some services that the government provides free of service, but the supplies and the supplies are very limited. There won't be around the year supply of medications, and even health personnel. You won't find a health personnel in the health facility around the year. And another important thing that is that the health personnel are not willing to go and work in the rural areas. So part of it is because there is very poor infrastructure, very poor facilities, that even if the health person goes there, they cannot do much. But the more important one is the health personnel are not trained in a way to work in a resource-poor setting. So that is the main constraint. So the medical schools that train the doctors, they are not focused on teaching them or training them towards working in a rural setting or working in a resource-poor setting. So they will be trained in a tertiary care level hospital, and suddenly if they are asked to go to work in a rural area, they are lost. Like the government of Nepal now has a provision that whoever studies medicine under scholarship, so they have to go and serve in the rural areas or wherever the government posts them. But they will be there in the paper, but they will not be staying there to work. because as I said, they are not trained to work in resource-poor settings, and they are scared. In fact, they have no idea how a rural setting functions. So people are not willing to go and work in that area. So with that background, like, this is Patan Hospital, which has been before that, the Patan Hospital there was a missionary hospital called Santa Bhavan that was established by missionaries, and later it was handed over to the district hospital of Patan area. And Patan Hospital has been working for quite a long time, and it is famous for its clinical services. People know this hospital for its good clinical service. So there was a point with the given background that I just talked about, the physicians working at Patan Hospital at some point started thinking that maybe, like, is it what we are doing is enough? If we look at the national perspective, that we treat patients come from different areas, all the referred cases, we treat them, we take good care of that. But is that enough? That was a question was raised. And the physicians came together and started thinking, maybe we should do something more than this to have an impact on at the national level. So there came the concept of PAHS. So the PAHS was established by the charter from the parliament in February 2008. And this was mainly, the reason behind establishing PAHS was to train doctors who will be capable of and willing to go and work at the rural areas. So the mission statement of PAHS states that PAHS is dedicated to sustain improvement of health of the people in Nepal, especially those who are poor and living in the rural areas, through innovation, equity, excellence, and love in education, service, and research. So the words highlighted in red are the most important ones in this mission statement. And as you can see, love in the mission statement, which you might not find in other in mission statements of other institutions. So what we think is, if you do not love whatever you are doing, or if you do not have a passion about your work, you won't be able to accomplish much. So that is why this word is there in our mission statement. So now coming to how PAHS is different. Like, there are so many, in a small country, Nepal is a very small country size-wise if you look at the map, but we have, I think there's 21 medical schools, and we produce almost 300 doctors per year, but still we have lack of doctors in the rural areas. So what we thought is, when we are developing a new medical school, our aim was not to just add, at that time when we started, there were 19 medical schools already, 18 medical schools already. So we didn't just want to become the 19th one, we wanted to do something differently. So what was that different thing that we took over, so there are something that I will go one by one. The first one is the admission policies, what kind of students we would like to take. The second one was the scholarship schemes. And then the educational strategies. We had a little different teaching learning methodologies and evaluation system. And finally, the continued follow-up and support of the graduates. So I'll go one by one. Like, what do we mean by different admission policies? Like, we have a different exam system, especially talking about the Asian subcontinent. The entrance examination for medical school is basically based on the physics, chemistry, biology, the biology questions and tests. And till now, there's no there's no absolute ideal way of taking an exam, how to select a medical student. There has been a lot of researches on what should be the test that will be ideal to take in the medical schools. But what we did was, we wanted a different exam. First thing is that the physics, chemistry, biology, they have already done in their +2, and they have their mark sheets with them, so there's no point retesting it. That means you are not believing on your own system of evaluation. So that was one thing. Second thing, we wanted to have students from all over the country. That is because the researchers have shown that if you recruit students from a rural background, so it is more likely that they will go and work in those areas after they graduate. So how to bring those people from all different parts of Nepal, from the rural areas? So if we have the conventional exam like physics, chemistry, and biology, naturally the ones who are studied in a better school, in a cities, will have a better opportunity to get in, because the people from the rural area would not have opportunity for good education. So if you have only the conventional exam, we won't be able to get more students from the rural areas. And what we did is we had like collaboration with the University of Newcastle in Australia, especially Professor David Poyes, who is also one of the members of our International Advisory Board. So in Australia, they are doing this PQA, Personal Quality Assessment. So they are using this test to recruit for the entrance examination of medical students. So what is done in that test is basically the personality traits and the mental agility test. So this is not affected by the opportunity you gain. So that is something inborn. Like that will also test the soft skills that a doctor needs to have. So what we do is we have this PQA, and we also have admission OSCEs. I think you call it MMI, multiple mini interviews. So we also have MMIs to test the skills that is needed, like for example, communication skill, decision-making skill, organizational skills. All these are tested by admission OSCEs. So after these 2 exams, we then have PAHS social inclusion matrix. What does that stand for is like we have an extra marks, additional preferential marks for certain group of people, for example, sorry, not this one. So the candidates who are from rural background or a backward region, the marginalized social group, caste or ethnic group, candidates who did their schooling from government school, because this reflects the economic condition of the family, if they do their schooling from a government school. And then candidates who worked as a mid-level health worker and served in the rural area, and female. This might be little, I mean, you might feel a little strange, why female? But in our part, there are very few medical students. In the medical students group, if you look at, there are very few females. So all these candidates will have a preferential marks. After they pass the basic exam, the PQA, the admission OSCEs or MMI, they have to pass the basic level. They have to have a minimal level of standard. After that, then they will have the PAHS social inclusion matrix will be added. So that's how we select the students. Sorry, this is the one. And then we have scholarship schemes. As I said that we wanted students from the rural background to come in and study medicine. But if we just say that, they cannot afford to study medicine. So we have to have some provision for scholarship. And we have like full scholarship, partial scholarship, and collaborative scholarship. So partial scholarship is half, 50% the candidate have to pay, and 50% the institute will waive for. And collaborative scholarship is like some person or some institute can sponsor a candidate. What they usually, what is done is that we have like districts, and certain district can sponsor a candidate. So the candidates from that particular district only have to compete among themselves, and the best one will be selected. So after graduation, that graduate will go and work in that particular district which has sponsored him or her. So this is what collaborative scholarship is. And the candidates who get scholarship, there has a service bond. So who study in full scholarship, they have to serve at least 4 years. And for partial, they have to serve 2 years in the area that the government sends them to. So this is how we have a service bond. And until they complete their bond, their final certificate will be held at PAHS. So this has made it mandatory service. So until they complete that, they don't get the final certificate. So sorry, again, I changed that. So with this system in place, we have 75 districts in the country. And out of 75 districts, we have students from 69 districts. So there's a lot of inclusion. With all these, we have been able to enroll students from different parts of our country. Now, as I talked about educational strategies, so what are the different things that we have tried or we have done? So we have chosen, under teaching methodology, we do PBL, especially in the basic sciences level, we teach through PBL. And during the clinical science years, we have clinical presentation curriculum. And both of these are like adult learning, self-directed learning ways. And in clinical presentation curriculum, student will be given some clinical presentation and how to approach to a particular problem, particular presentation. So they will be learning the problem-solving attitude through these process of teaching learning. And now community-based So I'll go one by one later. I'll just list out first. So the different strategies are community-based learning and education, ethics classes, working as a nurse, longitudinal patient follow-up, 6-month-long placement at district or rural hospital, and a different evaluation system. So this is the component of undergraduate medical curriculum at our place. We have a total of 6 years. So first 6 months is the introductory block, and then the 2 years of basic sciences. Then we have 1.5 years of junior clerkship, and 6 months of rural or district hospital rotation, and 6 months of senior clerkship, and 1 year of internship. So as I said, PBL and clinical presentation curriculum that will help students develop the problem-solving attitude, and at the same time that will help them learn how to work within a locally available resources and the limitation. And the ethics classes, like in many medical schools in our part, the ethics is not a subject that is taught in the medical schools mostly. And so what we do here is that is an interactive session. Students, the ethical dilemma or the ethical dilemma that they have come across or faced during their clinical posting or their clinical communication, they will come and discuss in a common forum in the group. So that is a mainly like discussion seminar, because as we know in ethics there's no right or wrong. Even the facilitator cannot say this is right and this is wrong. So there is basically discussion, and in that particular scenario, what would be more ethical? So those kind of a thing will be discussed. So from the very early on, these ethics sessions will be held, and with that helps, of course, in getting more professional and more ethical practice later on. So talking about longitudinal patient follow-up, students in their first year, starting from their first year, will be assigned some patients. So these patients will be patient with a chronic illness, a mentally handicapped child, mentally or physically handicapped child, some terminally ill patient. So students will be assigned some patients, and they have to go for the home visit. So they will go once or twice a month, and they will follow the patient for almost a year. So this is basically designed to make them aware of the social determinants of health. What happens when a person gets ill? What will be the effect in the family and the society? What are the difficult challenges that they face, economic or some like loss of work days, all those kind of a thing. So this will help students learn about those issues, and also that will encourage them to have a reflective learning, because this could be a very stressful thing for a beginner in a medical career, like to face a patient with a dying patient or a terminally ill patient. So at that point, what we do is we assign some mentors. It could be faculty or senior students. And after each home visits, they come to the mentor and talk about it, so that they will have some support, because sometimes it could be emotionally exhaustive when they suddenly see a dying patient or a patient with an incurable disease. So a mentoring system is in place. And working as a nurse, this we have started a very new thing. So that is before they just start their clinical clerkship, the first week they have to work as a nurse. So they will do everything a nurse does, like starting from the bed making, giving bath to the patient, preparing medications. So this is to foster the interprofessional relationship and to have a respect for each discipline. And as we know, medicine is a teamwork, so we want the students to learn the teamwork, how to be a good team player. And nurses, as we know, is a very important part of any medical team. When we started this thing, both the student, we had very good feedback. In the first year, first batch of students, we tried this, and we had very good feedback from both the students as well as from our nurses. So we have continued this, and this is something that it's a new thing that we have started. And talking about community-based teaching and learning, in our curriculum, 25% of the curriculum is community-based learning and education. A quite significant bulk is on this. And it starts from year one. The CBLE post in placement starts from year one, from the introductory block itself. And this is basically, it's experiential learning. Students get acquainted to the societal needs, and they will internalize their responsibility as a doctor in a given situation. And also through these postings, they will be exposed to the national health system as well. So if this is the in different years, over the 5 years of training period, they will be posted to the community 7 times. The last one is the district hospital or the rural hospital posting, which is the longest one, and it is like 5 months posting there. And the others vary from a week, 2 weeks, 3 weeks, 4 weeks, and they will be posted starting from the very basic level of health facility to the district level. So they will be acquainted with all the steps of health services in the country. So these are some of the glimpses. So in one of the community posting in the very beginning, what we let the students to do is the students will be living with the community people in their house as one of them. So this is the picture here is that the faculties were there to visit the students, and I'm just coming here. So these are 2 of our students. They were living, sorry. How to get back now, I don't know. Okay, previous. Okay. So these students were living in this rural house, and the house had a cow shed just behind where they lived. This was the room they lived in. And these 2 girls, they were born and reared in the city. They had never been to a village. So in this way, that they will get exposed to a rural, what it is really like to live in a village. So and this, so they are in like a pair of students will be kept in different houses, and we were just visiting, and this is also 2 other students, the faculty interacting with them. It was almost a late night. So in the community, when we go, these are the community people, and we are here, the faculties are here, we interact with them, we decide which houses to keep them, and the community people, especially the female group, is very active in that particular district. So they tell us and guide us where to put, looking at the security and everything. So these are also some community people, some of our students. So this is the field posting. And so these are on different, at different level health facilities when they are posted, when we go there and visit them. So these are some of the pictures there. And now coming to the 6-month-long district posting, as I said, it is at the final year, the last year of the training. So we have a concept of teaching districts. So we have 4 teaching hospitals. We have teaching districts that are assigned to where our students are posted at different levels of health facility. So basically this is learning in the context, like so that they will visualize themselves as a doctor when they will graduate in that particular place with the given resources. So they will try to visualize themselves like what I'm going to do when I graduate and come to a place like this. What can I do? What are the limitations? What skills I need to learn more when to be able to come here and work once I graduate. So this is an early exposure, and this is an early internalization of their role as a doctor in a rural place. So the teaching, learning, and supervision is usually the local preceptor will be the MDGP there, and the PAHS faculties will visit there time and on. And we have foreign faculty visits, and this is mainly through the Canadian faculties. This is Professor Carl Stobbe has coordinated this, and the Society of Rural Physicians all have sent like faculties, rural faculties there, and they come there for about a month, and they stay 3 to 4 weeks in these districts to supervise and teach our students during the rural visits. And among those faculties visiting from Canada, Russell was there once and helping us to find out what are the ways that we can improve on the rural training. So, we regularly get Canadian faculties to visit there and teach and supervise our students. And we also have like visual classroom. Like once a week for all the 4 sites, we connect from PAHS, and we discuss a case, or a problem. So the cases will be given them beforehand. They will discuss with the preceptor, local preceptors, and they come up with a presentation. And all 4 sites will be connected. And this VCR also, we got a donation for this, the funding through Professor Karl. We got that, and it is working quite well to get connected with the students who are in the rural facility. And as I said, we have a different evaluation system. Again, in most of the medical schools in our part of the world, the examination system is conventional exam. Like they have the end of the rotation summative exam, and that decides whether the person is competent enough to be a doctor or not. At the end of 6 years, they suddenly have a big exam, and that tells you whether you are competent enough to practice or not. But what we do is we have a continuous evaluation. We have a lot of formative evaluation, and a very good feedback system is there. One-to-one feedbacks are given to students, and also there's group feedback system. And like we don't have a ranking system. So after each exam, we don't give the students how much marks you have obtained. We only give them a range. You have obtained between this and this, within this range. So we try to avoid the unhealthy competition between students. And what we want is, we don't want a few very excellent doctors. We want all good doctors. So for that, we want to encourage the team learning, group learning, and to make everyone a good doctor to be able to practice in our rural setting. And another important thing is that process evaluation. Not only the content evaluation, we also do process evaluation. And what we do in that is we evaluate the non-cognitive dimensions, like how they behave when they are in the ward or with the patient or in the OPD or in the community, how they behave, how they talk with their colleagues, whether they have respect to each other or not. So these will be evaluated by the faculty as well as by the community people when they'll be in the community. Like I said, when they are staying in the houses and the community houses. So the member of that house will be evaluating our student. And if they fail in the process evaluation, the candidates are not allowed to sit in the content evaluation test. So they have to pass the process evaluation. So this is basically checking them on their professionalism, making them responsible from the very early on. So till now, we have 2 batches who have completed, who have graduated. This is the first batch of graduates. We had 54 candidates, and all of them passed. Whoever appeared for the exam, all of them passed. This is the when they passed, this was a celebration thing. And all the students also, we have a national licensing exam. We call it the National Medical Council exam. And all of them passed that exam in the first go. So that was a good beginning for us. And we have the second batch. We had 63 in this batch, and they are now doing their internship. So now talking about advocacy for creating enabling environment for the graduates. Like after they pass, as I said, that for the scholarship students, they have to go and work in the rural area. But for this, we have to negotiate with the government because the government has to place them. So we have to have a vacant spots where the government can place them. So we had to do a lot of advocacy with the government regarding the posting of this student, but we were lucky enough that the government responded quite well, and we were able to post all of our the scholarship students to different parts of the country. And we would also like to have a continuous support system for these students, like they will be there for 2 to 4 years. So we don't just leave them there. Now you are done from PAHS, you can go and work. So we want to have a continued support system. And for now, we don't have a proper system in place, but what we are doing is whenever they find difficulty handling a case or a situation, then they contact our faculties through text messages or X-ray pictures through Viber, and all our faculties respond to that. So that has been a supportive system. So, and the students the graduates highly appreciate that as well. But we are thinking of having some structured way of support as well. We are planning to develop that. And we are also looking forward to having follow-up meetings, like regular meeting once a year, meeting all the graduates posted in different areas. So these are all in our plans so far. And this is the map of Nepal, and the red dots are the number of students posted in different parts of the country. So there are 31 students who are from scholarship stream, and they are posted in different parts of the country, starting from east to west, the mountain, recent, Tharai. So we have these graduates placed in different places. And now, I mean, it is too early to say comment about the performance of our graduate, but there's some early things that we could get is that what we have heard from people in the community or talking to that. So what they have given us feedback is they find the graduates from PAHS different than other graduates, especially regarding the communication skill. They have appreciated that our graduates communicate very well with the patients. And also the regularity, their presence. As I said, like the doctors will be posted to rural areas, but they will be only in papers, as they are not trained to, work in a limited resource setting. So they will be there in paper, but they will be not physically present there. But when we started posting our graduates, the comments that we heard is now that they are very regular. They are there where they are posted throughout the time. So that made the service improvement. The number of patient flow increased in those areas, those health posts, the primary health centers and district hospital, wherever our graduates are. Because when they know that a doctor will be there regularly, then the patient, rather than going outside or going far away, they would like to come to the nearest place where the doctor will be. So the service number of patients has improved. And we have people have appreciated their administrative skill, because these students are posted so frequently and exposed so much to the health system. So they are in the public health offices. They are at the final year, as I said, the 5 months, they will be working, they will be doing clinical work, as well as they will be posted to the district public health office. And they will learn the administrative skills, where from the medicine comes in, how to fill a demand form for medicine. All these things they learn beforehand. So that will help them a lot to work in a district as a team leader. So another important thing is they know how to build relations with the local bodies, how to communicate and how to build relation with the local bodies. And some of the initiatives, like after 3 months in their rural posting, the graduates had come to Kathmandu to appear for an exam. That exam was to enter into the government service, the permanent government service. And while hearing to them, what they shared is in some of the some graduates who are posted in the district public, in the primary health care centers, they were able to negotiate with the local bodies and bring significant amount of fund into the PSCC, the primary health center where they worked, so that they could establish a separate pharmacy there. They brought so much of instrument through donations, so they were able to negotiate. And the students were sharing that in one of the PSCC, the graduate was able to negotiate with the local people to donate a land where they could expand their service. And another graduate was shared his experience that when he went there, he saw 2 neonatal deaths. After that, what he did was nearby there was a private hospital. He negotiated with them, got some resuscitation instrument from them, and he made a link for the referral system, because that was the nearest hospital. So these kind of things our graduates were doing quite well. And just 2 weeks ago, like one of the graduates, as I said, had a local pharmacy built in within his PSCC, and the government officials went there to inaugurate that. So these are something very early, very early to say that there has been some difference we can expect, but we still have to wait and see how they will perform. So what is the way ahead? Like for the creating the more enabling environment. So we have continued dialogue with the government for the next batch of graduates coming, and then for the infrastructure development in the areas where they are posted, and setting up a system for continued link and monitoring, and again continued medical education develop a system for that, and short-term trainings, exchange programs. So these are the things that we need to work on. And in 2017, we'll be starting postgraduate training at PAHS. So we have decided to put some preferential marks for the graduates who have worked in the rural area. while getting enrolled into the postgraduate program as well. So we have a lot of international partners and collaborators starting from the very beginning, from the inception of PAHS. We have many universities which has helped us and which are helping us. And we can see Memorial University there as well. We have a MOU with Memorial University. So a lot of people from all different parts of the country has contributed to bring in this system and to continue this system. And we wish that this support will continue. I think that's all of my presentation. Thank you. So if you have any questions, or we'll answer the questions at the end. Okay, thank you.
I'll take this for
Yes, so I don't have to turn it on? It's already on?
So thank you very much, Dr. Shrestha, for this really very interesting, comprehensive presentation. Some of the things that you said struck a chord, because at Memorial also the admissions takes into account where the students come from. And one of the things that Memorial is very proud to say is that it has students from all the 5 quintiles across the income spectrum, and it also actually has given priority to rural students. The other part which struck me while you were presenting about the mission and vision of PAHS is the social accountability, and that too is something which Memorial is very proud of, because it has focused on that, and it actually received an award from Aspire for that social accountability. But I will not continue. I could continue to talk a lot about it, but I would like to introduce our next speaker, Dr. Chitish Podel. He trained in China and spent 1 year learning Chinese, and was, straight away put into learning medicine through that process. So I just think about the challenge it is to learn a new language and then to be able to work in that language. He then went on to do his residency in general practice at the National Academy of Medical Sciences in Kathmandu. And as a resident, he did the bulk of his clinical training at the Patan Academy of Health Sciences. So he began his rural work in Ampipal, Nepal, as a general practitioner in 2014, and has since that time been serving as a medical director in that hospital. For the past 2 years, he has been teaching and supervising PAHS medical students during their rural rotation at the Ampipal hospital. And in 2015 was appointed as a lecturer at PAHS. So he too is on this trajectory of working in rural medicine and providing the support that is required for that. So thank you very much, and you're going to talk about the challenges that you have faced in the hospital as a generalist. So thank you.
Okay. Good afternoon. My talk would be challenges in rural practice in resources-poor settings. I work in one of the rural hospitals, one of the rural sites where Patan Academy medical students go in their final rotations for rural rotation. So I think this is something that you have to say. So I have no affiliation with any pharmaceutical company or anything for this presentation. So I'm a lecturer at Patan Academy of Medical Sciences, as Dr. Sri explained before, and I'm a general practitioner working in one of the rural areas in Nepal. So just to give you an idea, maybe not all of you are aware of Nepal and all. It's a small country sandwiched between two big countries, India and China. It's like that. And our population is about 30 million, and about 83% of them reside in rural areas. That's according to our last census done in 2011. And providing basic health care is still a big challenge, and substantial challenge. So just to give you an idea, sorry, what happened here? So I'm just going to talk about the hospital that I'm working at, and the challenges that I faced would be more generic challenges common to all these rural hospitals. But the things that I have tried to do is more specific to the hospital that I'm working at. So our People Hospital is in midwestern part of the country, and it's southwestern part of the particular district it is located in. And the hospital is located at around altitude of 1,100 meters. So that red one is the district where I'm working at. And the red circle would be the area inside the district where the hospital is located. So if you take a Google view, that looks a little bit bleak. It's a small hospital in the middle of nowhere. So this one is taken about 2 years, maybe more ago, when before that devastating earthquake struck. It was taken from the hilltop nearby. So our People Hospital is one of the 4 rural rotation sites for Patna Academy of Health Sciences medical students. It's a 46-bed hospital, 2 operation theaters, and the capacity has been reduced to 30 beds since the earthquake. So it has a hospital staff of about 46, and out of that, 22 staffs are clinical, and I'm the only GP working there, and I have a GP trainee, and one of the house officer is a recent PAHS graduate, and she was also my student who did a rural rotation there, and then she chose to come and work there, and so she has been there with us for the last 4 months. And health assistant and A&Ms, these are mid-level health workers. Probably A&M is probably nurse practitioner or something here. Sorry, HA. So just to give you an introduction to some Canadian connection with the hospital particularly. She is Dr. Helen Isabel Houston. She worked there since 1960 to 1992 as part of a United Mission to Nepal, and she was retired in 1992. So now, that hospital receives some help from German people, and there's an organization, NGO called Nepal Med. So it's been run by Dr. Arne Drews. He's a pulmonologist, and then he's a major fundraiser for this organization, and then they also help us with infrastructure and equipments and all. So this is how our hospital would look like, the wards and everything. So this is round, I'm taking the rounds, and these are the students when they're posted there, so I'm taking rounds. So this is an emergency laparotomy that I was doing for a bowel obstruction, small bowel obstruction. This left humerus supracondylar fracture. So this is a thigh fracture of a 4-year-old, and then we did intramedullary nailing. And this is an emergency C-section. It's total abdominal hysterectomy for PV bleeding for 5 years or so. This is a vaginal hysterectomy. And this is our busy OPD section. So we get about 60 to 65 patients a day. So this is our outpatient. So let's talk about the challenges. It's lack of resources and poor road access to the hospital. poor medical record system we have, and teaching medical students is also an added challenge when you are working as the only GP, and also this professional isolation and personal isolation. Lack of resources. Well, it's difficult to get skilled staff, and then even more difficult to retain them there. I think it's same everywhere, all over the world, in rural areas especially. And also other problems are infrastructure. We have these leaky buildings, and then that they are even worsened by earthquake and all these things. And it's lack of essential equipments, pulse oximeter, ECG machines, oxygen concentrators. But we are lucky, Apipa Hospital is lucky in a way that our infrastructure and then essential equipment, we didn't have that much of a problem because of this Nepal-made NGO. It has been helping us getting with these equipments and all. And sometimes this rural hospital also faces this problem of this pharmacy. You do not have essential medicines, and this very poorly stocked pharmacy, and then poorly maintained supply chain. And what we are doing to solve that problem, we try to train these ANMs and HAs. These are mid-level health workers in our country. This ANM is auxiliary nurse midwife, and HA is health assistant. ANMs are basically mid-level nursing staff, and HA are mid-level doctor staff, let's say. So we try to train them to meet our needs there, and try to retain them there. And we also try as best as we can to hire local as far as possible, and to improve the chances of retention. And we also get help from students, residents, and local and foreign faculties. As our dean mentioned, Canadian faculties visit our rural site as well. They stay there for extended period of time, 3-4 weeks, and we also get some help from them. And we also write grant requests and other things to Nepal-made for equipment and infrastructures. And for our medicine supply and all, I usually sit with pharmacists every other Friday, and we go through the inventories and then make a list of these things, whatever medicine we have or which is about to expire, and we work out a list for next 2 weeks, and we send out the list to the supplier, and then within next 2 weeks we get the supplies. So this is Apipa Hospital right now, post earthquake, and then we are doing working with Japanese International Cooperation Agency for the reconstruction of this OPD and ER complex, emergency room complex. And this is what it will look like after the completion of the project. And sometimes we get a grant from the Nepal government as well to purchase equipment and all. So this last year we got some grant money from Nepal government, and then we acquired some equipments. And this one is a phototherapy unit for neonates. And sometimes we just have to improvise. And about poor road access, this is the a stretch of the road that looks better. Once it rains, it's really messy. It looks like a stream, actually, not even a road, and it's very difficult for the patient, especially if you have to refer patient, if you have trauma patient, you suspect spinal injuries and all. So it's very difficult to refer those kind of patients. And most patients, they walk to the hospital, and their walking distances from half an hour to a couple of days, more than a day. And sick and elderly are usually carried to hospital in one of these locally improvised carriers. So this is how they would come. And this is 83-year-old lady, and this is a 67-year-old man. And for this poor road access, we are working, the hospital is working with a local government body to build a road. We have committed about 1/3 of the funding that is required. The hospital has committed that much, and we just hope that we can get at least all seasons gravel road for this year or in next 2 years. And the other thing is that this Safe Mother House, we are building Safe Mother House this year with government grant and all. This is very important for us because these pregnant women, they come from very far-flung places inside Gorkha district. They have to walk like 10 hours, like 14 hours maybe a day, and they are late into their pregnancy. They come to the hospital, and then you diagnose them that, oh, okay, you have false labor, and then you send them out, and on the way they can deliver babies. So it's a little risky to send them home after that. So I was thinking maybe we can build a house inside the hospital premises, so that would house them there till they deliver the babies, and then once the baby is delivered, and we can send them out. So it's just kind of motel for them, kind of, and then they would stay there till their labor starts, and then once the labor starts, they will be shifted to the hospital labor room. And also we are working with the locals to create kind of ambulance map, so to speak, meaning we have 2 ambulances, and not all the places in Gorkha, in Apipal, VDC, or in Gorkha district, wherever we serve, not all the places are accessible by vehicles or ambulances. So we want to create a kind of stop, like bus stop or something, ambulance stop, where the ambulance can go and where the people have to come or walk down to. So they will call, and then they will mention that particular place where they would be standing, and the ambulance would go there, and once it reaches there, then they can collect the patient from there. So we are working on that. Our drivers are working on that. So we are gonna have 2 different versions of it, like autumn version and monsoon version, because in monsoon time you have this very difficult. It's very difficult for any kind of vehicle to drive in those kind of roads in monsoon. So this is the Safe Mother House that I was mentioning. It's being built, and the picture was about 2 weeks old, I guess. So it will house about 6 pregnant mothers at one time, and one of these low middle level staff will be assigned there. She will be looking after all these mothers, and doctor will visit there a weekly round, like a Thursday or Tuesday or something like that. And once the lady goes into the labor, she would be wheeled into labor ward, labor unit. So now the next challenge that we are facing about it's poor medical record keeping, and it's mostly in this format that we have these medical records, and well, it requires a dedicated physical space to store, and it's hard to come by in all rural hospitals and that kind of thing. And it's easy to lose, and then even if you have a physical space, it's very difficult to retrieve if you want to do any kind of meaningful research. And so probably that's one of the reasons why there's very little research in rural areas. So and so I was thinking maybe I can convince our hospital administrators and others that we can switch that into an electronic format. So we are trying to implement this software called Bhamini. It's an open source software, OpenMRS. One implementation of that OpenMRS software. It's first implemented in Maharashtra, I think, in India. The village name is Bhamini, so that's how it got its name. And it's a hospital system for low resources setting. And it would be good to have trains, what kind of trains we have, seasonal trains and everything, that will obviously help with this policy making and then this policy decisions and everything. Even just for the hospital administration as well, what kind of stuff, what kind of medicine to order and all these things. And beyond that, we can do a retrospective studies and other things. Well, about professional isolation, well, there's when I went to work in that hospital, People Hospital, about 3 years ago, we didn't have landline phone. We still don't, because it's a sparsely populated area and it's in a mountainous region, and then nobody saw it profitable to have landlines there. So we have cell phones, but it's still a poor reception. So that's all the way to connect to outside world. A smartphone or a cell phone, that's all. And when you're working alone, at that time I was working alone, I was the only doctor, and then there are a moment of profound doubt. I mean, you want to talk to some person, in person, it's not on, and you try to call, and then the reception is so poor that you have to just run around the hospital premises just to get a better reception. And so you just have this genuine wish that you could talk to someone and then, explain the situation and get a feedback, or just like that. And it's difficult. And the other thing is that you become an afterthought, because you are out in the rural area, and then sometimes people forget that you are working there because there's no way for communication, and there's a training, there's a whatever in urban areas. They just simply forget that you exist and you are working there, and probably you might need that kind of training. So you just become an afterthought. So that professional isolation was a little bit overcome by this PAHS VCR project that our dean just mentioned. That's a virtual classroom project for these Patni Academy students who are posted in rural areas. They attend a class every Friday through a telecommunication kind of thing. So you have a fast internet connection, and you have this video conferencing. The faculty will take a class from Patni Academy site in Patni Hospital, and all 4 rural sites, they would come up online, and then they take a class online. So for that project, they had to bring a fast internet connection to that area, and that changed this consultation and everything forever. So with that, I started teleconsultation with one of these doctors called Dr. René Kalisch. He's a German trauma surgeon. So it's more like a synchronous store and forward email type of thing in the beginning. It still is with this Patni Academy, because we cannot have two-way real video conferencing with that, at least for this telemedicine purpose. But for that, we have built another one. Okay. So this is how it will work. It's just like store and forward. You get emails and everything. So I just give you one real example how we worked out this. This is a femur fracture of a guy who came to us. He didn't have any money. He just doesn't even have 10,000 rupees. So he couldn't go anywhere. And I never had done femur fracture surgery before. So we're stuck there. So then I wrote a long email to this trauma surgeon, and then he writes me back, and then this conservative treatment is not an option. You have to do an operation, and how to do operation and everything. So he describes me those things in replies. He was replying from Berlin. So he gave me these pictures to work with, and I just went through this chapter of this femur fracture plating and then all these things. And this is the outcome. So that's what we did. And for now, with this group called Nepal Wireless, there's this group called Nepal Wireless. They have donated us equipment and everything for real-time video conferencing right now. So we have started a year ago, to this date, I think it will be a year now. So we now have this real-time video consultation with Kathmandu Model Hospital surgical team. This is still a trial phase, and they have all the equipment that is required, this Polycom software and then devices. And that software was also donated to us, so we can communicate directly with them. So for now, it's with them. And they also have a Viber chat group. WhatsApp is very common in this part of the world, I think, but Viber is a very popular chat program in our part of the world. So we have this kind of chat group where we discuss about things and everything, all these things. We do have a GP-specific Viber chat group as well. That's where they discuss, they mention about these things, whatever they have done and all. And so that GP stuff was started by a couple of us 2 years ago. It was started by Dr. Sandeep GC, and I was the earliest contributor, and then we made sure that there's no person who is responsible for everything in that group, meaning like who can get into the group or something like that. And that made it easier for everyone to add to the chat group other members. So teaching medical students, it's in that condition, in that situation, it's really challenging. It demands more of your time, energy, commitment. And sometimes I do get this non-native speakers as a student, mostly from Germany, Austria, Switzerland, and also sometimes from UK. And so far we've gotten one Canadian trainee, GP trainee. So it's a little bit challenging with those. And about personal isolation, well, it takes time away from family events and milestones. You cannot visit family as often as you would want to, and there's no real possibility of socializing or anything. I don't think there's anything much you can do about these things. That's just inherent into the profession, some kind of professional isolation. Other things I think that you can improve upon is if you have good road access, then probably you can visit your family more frequently. And if you have more doctors coming to the place, and when you are away, there's a doctor taking your place instead and working there, then it would be easier. So that's what we are working right now. So we have this PAHS graduate where she's working there for 4 months, and then it has been very valuable for us, many things, and also for me to take leave. Yeah, for just to come here, I had to, I think I had to make other arrangements as well. So I talked to like 2 German trauma surgeons so that they would overlap 4 days, and then they would at least be there for 4 weeks, 4 weeks between them, and 1 gynecologist. She would be there for the next 4 weeks, and 2 Nepali doctors. So that would be about, I don't know, 5 doctors there. Yeah. So that would be it. Thank you.
So, my apologies again for our late start this morning. We have approximately 3 minutes for questions. Dr. Shrestha and Dr. Tivich can both weigh in. Let's take, your top 2 burning questions. That's in the room. David?
Dr. Shrestha, I was interested in your comment about, the students going to rural hospitals for their, as they go on in training, closer to a district hospital and so on. But at in their first posting, they're often out in hospitals on their own. How frequently do they find themselves in their first posting in a situation where they would be tutored by somebody like Dr. Podell? Are they working on their own? They're
Under supervision. We don't leave them on their own. Only like after they graduate, only then they are allowed to work independently.
yeah.
Otherwise,
So
mostly they will be supervised, under supervision. They will be working.
as graduates, how much supervision will
No,
they
as
have?
graduates, they could be all alone in the primary health center. So they have to take their own decisions and they have to see patients on their own. So if they have some doubts, the only thing they can do is they can communicate and ask questions to the faculties. So otherwise, like in the district level hospital, there might be some other doctors too, but in the primary health centers, he or she might be the only doctor there.
So the irony is that you get to work on your own in isolated situations before you get to come back for postgraduate training.
Yeah. That's why we need to develop a separate kind of training program to make them able to go and deal with the common problems there.
Good. One more question?
All right. I was wondering about the possibility of scaling up the institute
Scaling up in terms of?
in terms of the number of students that you train, or expanding it in the number of, to other areas of Nepal.
Okay. So like it's an academy and it cannot give affiliation to other colleges. So the number of students, like we have each year, we have 60 students. And from this year, we have increases to 65. But we are not planning to increase the number so much because the training program that we have is very faculty intensive. And so it's a small group teaching. Like we don't have big lectures and the whole group, like there are very few lectures. So it's very faculty intensive, not only the teaching program, but also the evaluation system, because it's we are trying to do it as a competency-based training. So we have to assess each and every student on their competencies. So we are not thinking of increasing the number so much for now. So later, if we have a lot of faculties, a lot of space for small group teachings, then it might be a possibility. But for now, probably our maximum might be like 70 if we dare to increase further. Otherwise, we are not trying to increase the number. But regarding other programs, like in 2017, we will be starting the postgraduate programs. And on that also, our top priority is the GP training, MD-GP, because that is what the country needs. Like as you heard Chiti's presenting, he's doing a lot of things, like starting from the cesarean section to nailing and doing orthopedic surgeries. So GPs are what is needed in the context of Nepal. So we are planning to train more GPs rather than other specialities. And we are the program of public Masters in Public Health, MPH, is also in pipeline. So most probably we'll start that also in 2017. And we are also thinking of doing some like allied health sciences programs like physiotherapy and radiology. Those kind of things also are in pipeline. The ones that will start in 2017 is MPH and post-graduation, the MD-GP programs.
All right. So thank you very much for coming, and thank you once again to Drs.